Welcome back to the deep dive. Today is going to be a little different, and honestly, I am really excited about the intensity of this one. We are shifting gears from our usual exploration to a dedicated high-stakes study session. We want you to imagine that you are an MD anesthesiology student. Maybe you're preparing for the Gujarat University exams or maybe the DNB finals, and you are staring down the barrel of the long case.
That's exactly right. We are not just chatting today. I'm putting on my senior faculty hat. Think of me as the internal examiner who wants you to pass, but I am going to be strict. My goal here is to show you exactly how to structure your thoughts, where the traps are, and how to construct that perfect answer for anesthetic management of total hip replacement, or THR.
I love that setup. So I'll be your study partner, the one making sure no concept is left unexplained and pushing for those specific details that can really make the difference between a pass and a distinction. We've got a huge stack of sources here. Miller's anesthesia, Morgan and Mikhail, ICU protocols, and even some specific notes on past exam patterns. Our mission is to cover everything, from the basic definition all the way to crisis management of something like bone cement implantation syndrome.
It is a classic exam topic for a reason. It tests everything. It tests your grasp of geriatric physiology, your understanding of regional anesthesia, your pharmacology, and crucially, your ability to manage a sudden intraoperative catastrophe. Let's be clear. If you can handle a THR case well, you can handle almost anything in orthopedic anesthesia.
Okay, let's start at the very beginning then. Part A, introduction and surgical overview. You're standing in front of the examiner or you have that blank answer sheet in front of you. How do you start? How do you frame this introduction?
You start with precision. Don't just say, it's fixing a hip. That's not good enough. You must state, total hip replacement is the surgical replacement of both the femoral head and the acetabulum with prosthetic components. That distinction is absolutely key, because if you're only replacing the femoral head, well, that's a hemiarthroplasty, and you need to show you know the difference.
Right. And then immediately after that definition, we need to frame who is getting this surgery, don't we?
Exactly. This is where you introduce what we call the anesthetic challenge. The vast majority of these patients are geriatric. They are elderly, often frail, and they present with what I like to call the geriatric package. They rarely come with just a bad hip. They come with hypertension, ischemic heart disease, COPD, diabetes, and some degree of reduced renal reserve.
So listing the indications isn't just a formality. It's a way to tell the examiner about the patient's underlying physiology.
You've got it. The most common indication is, of course, osteoarthritis, degenerative joint disease. That's your standard elderly patient with a wear and tear problem. But for the exam, you must mention the others. They carry specific anesthetic red flags. Rheumatoid arthritis, or RA, is a major one.
Okay, let's pause right there on RA, because that sounds like a frequent Viva trap. Why is RA so significant for us as anesthetists?
Because RA is a systemic disease. As soon as you see RA on the patient's chart, your brain should immediately scream two things: airway and cervical spine. You have to assess for atlantoaxial instability. The odontoid peg can become unstable, and if you blindly extend the neck for intubation, you risk compressing the spinal cord. It's a catastrophic complication.
That's a terrifying thought. So the whole approach to airway assessment is different.
Completely. Plus, you have potential TMJ involvement, which limits mouth opening. You can have cricoretinoid arthritis, which can narrow the glottis. It's an airway challenge from top to bottom. Then you have other indications like avascular necrosis, AVN, often linked to steroid use or alcohol, and, of course, traumatic fractures, the classic neck of femur fracture in an elderly person who has had a fall.
And those Chromon patients are a different beast entirely compared to the elective osteoarthritis patients, right?
Oh, absolutely. The trauma patient is an urgent case. They might be dehydrated, they could be in shock from occult blood loss. You can easily lose a liter of blood into the thigh and not see a drop of it. And they might not have been fasted properly. They are in immense pain, which causes a sympathetic surge that their frail heart just might not be able to handle.
Okay, we define the patient, we define the risks. Now let's talk about the surgery itself, the carpentry. The type of surgery matters a great deal for our plan, especially when it comes to the cement.
This is a very high-yield topic for your exam.
Right.
You must be able to clearly distinguish between a cemented THR and an uncemented THR.
Let's break those down. Cemented first. What are we talking about?
Cemented THR uses something called polymethylmethacrylate, PMMA, which is basically a bone cement. It acts as a grout to secure the prosthesis in place. The surgeon mixes a powder and a liquid, it gets hot, and they force it under high pressure into the femoral canal. This is often preferred in elderly patients with osteoporotic, weaker bone because it provides immediate stability. They can walk on it much sooner.
But from our perspective, as soon as we hear the word cemented, we should be thinking danger zone.
That's correct. To get that cement in, they have to pressurize the femoral canal. And that pressure forces a shower of fat, marrow, air, and cement debris directly into the venous circulation. This is the exact setup for bone cement implantation syndrome, or BCIS. If you're managing a cemented hip, you are on high alert.
Okay, so what about uncemented?
Uncemented uses a press-fit prosthesis. It has a special porous coating that allows the patient's own bone to grow into the metal over time. The big advantage for us is that it dramatically lowers the risk of BCIS because there's no high-pressure cementing event. But the downside is that it requires healthy bone stock, so you tend to see it in younger patients. And the rehab is slower because you have to wait for that biological fixation to occur.
And just to round it out, what about hemiarthroplasty?
That's when you replace only the femoral head. It's usually done for fractures where the acetabulum, the socket, is still in good shape. It's a bit quicker, usually has slightly less bleeding, but it's most often done in the very elderly and frail, so the overall physiological risk remains very high.
Okay, great. That brings us to Part B, pathophysiology and intraoperative events. We mentioned the geriatric package before. Let's really do a deep dive into that. What are the specific physiological challenges we are facing with an elderly patient on the table?
You have to demonstrate to the examiner that you understand the aging cardiovascular system. It's not just that the heart is old. It's stiff. The arteries are stiff, which leads to systolic hypertension. But the real key, the concept you must mention, is diastolic dysfunction. The left ventricle itself becomes stiff and non-compliant.
Which means it has trouble filling with blood.
Exactly. These patients become heavily dependent on the atrial kick, that final squeeze from the atria, to properly fill the ventricle. So if they flip into atrial fibrillation during the surgery, they can lose 20, maybe 30% of their cardiac output instantly. It can be a disaster. They also have a very narrow window for fluid management. They don't tolerate hypovolemia because that stiff ventricle needs good pressure to fill, but they don't tolerate fluid overload because that pressure backs up into the lungs almost immediately.
And what about the respiratory system? I see closing capacity is highlighted in all the high yield notes.
This is a favorite physiology question. As we age, our lung tissue loses its elastic recoil. This means the small airways have a tendency to collapse earlier during exhalation. Closing capacity is the lung volume at which these small airways begin to shut. In an elderly person, the closing capacity increases, and it can actually exceed their functional residual capacity, the FRC, especially when they are lying down.
So you're saying that even during normal, quiet breathing, parts of their lungs are collapsing?
Yes. Just by having them lie on the operating table, they are developing atelectasis. This creates a VQ mismatch and can lead to hypoxia. Now imagine you give them a general anesthetic. You paralyze them, the diaphragm moves up, the FRC drops even further, and that atelectasis gets much, much worse.
This is all crucial context, which brings us to the absolute core of this entire topic, the pass-fail concept you mentioned, bone cement implantation syndrome. BCIS.
Let me be very clear. If you're asked about THR in an exam and you do not discuss BCIS in detail, you will fail. It is the defining crisis of this surgery.
Okay, so let's define it formally for the examiner.
BCIS is a syndrome. It's characterized by hypoxia, hypotension, and cardiac arrhythmias, potentially leading to a full-blown cardiac arrest that occurs around the time of cementation and insertion of the prosthesis.
What's actually happening? What's the mechanism? I know there are a couple of competing theories.
The dominant theory, and the one you should explain first, is the embolic model. Remember that high pressure inside the femur. It can exceed 500 millimeters of mercury. That pressure acts like a shotgun, firing a shower of debris, fat, marrow, bits of cement, air directly into the large femoral veins. This toxic mix travels to the right atrium, the right ventricle, and then gets lodged in the pulmonary circulation.
So it's a mechanical obstruction in the lungs, like a massive pulmonary embolism.
Precisely. It causes a sudden, dramatic rise in pulmonary vascular resistance, or PVR. The right ventricle, which is a thin-walled chamber designed for a low-pressure system, suddenly faces a brick wall. It cannot cope. It dilates and it fails.
And this is what leads to that death spiral I've read about.
That's the term for it. The acutely dilated right ventricle is so big it pushes the interventricular septum over into the left ventricle. Now, the left ventricle is small and can't fill properly. You get what's called a D-shaped septum on an echo. Cardiac output crashes. Hypotension is profound. And because of all the emboli clogging the lungs, you have massive VQ mismatch and shunting, leading to severe hypoxia.
And what about the chemical component, the monomer from the cement?
That's the second theory. The idea is that the circulating methyl methacrylate monomer itself is a potent vasodilator and has direct myocardial depressant effects. While it certainly plays a role, the current consensus is that the overwhelming mechanical obstruction from the emboli is the primary driver of the cardiovascular collapse. The monomer adds insult to injury.
So clinically, what does this triad look like in the operating room?
1. Hypoxia, your saturation will plummet. 2. Hypotension, the blood pressure will fall off a cliff. 3. In an awake patient under regional, they might lose consciousness. Under GA, it can present as a sudden cardiac arrest.
And the key monitor sign, the very first thing that will tip you off.
A sudden, catastrophic drop in your end-tidal CO2, your ETCO2.
Why does that drop so sharply?
For 2 reasons. First, cardiac output has crashed, so less CO2 is being delivered from the tissues to the lungs to be exhaled. Second, the emboli creates a huge amount of dead space ventilation. You're ventilating parts of the lung that are no longer getting any blood flow. If your ETCO2 drops from, say, 35 down to 15 during cementing, your first thought should not be, is the circuit disconnected? Your first thought must be, is the patient arresting? Check the pulse, check the arterial line.
That is a critical Viva trap. Okay, Part C, preoperative assessment. The patient is in the pre-op clinic. How do we structure this evaluation effectively?
For any geriatric patient, I want you to think about the 4 M's: mentation, mobility, medication, and multimorbidity.
Mentation. That's checking for delirium risk.
Right. Yes. You must document their baseline cognitive function. Are they already confused? If they're confused pre-op, they're almost guaranteed to be confused post-op. It helps manage expectations for the family and the surgical team.
And mobility.
This is your best assessment of their functional capacity. The classic question is, can you climb 2 flights of stairs? That's about 4 METs. If they can, their perioperative cardiac risk is generally acceptable. But often with a hip fracture, they can't walk at all. So you have to be a detective. You have to ask, what could you do before you fell?
Medication is obviously huge, especially with anticoagulants and antiplatelets.
You need a forensic level of detail. What exactly are they taking? Is it clopidogrel? Warfarin? Is it a DOAC like a Pixaban or rivaroxaban? If you are planning a spinal or epidural, you absolutely must know the recommended stop dates. For something like clopidogrel, that's typically 5 to 7 days. For warfarin, you need to see a normalized INR.
And multimorbidity. We talked about the heart, but I want to specifically ask about aortic stenosis.
You must listen to the chest. If you hear a systolic murmur, you need to be suspicious. Severe aortic stenosis is a fixed output state. The heart can't increase its cardiac output on demand. If you give that patient a spinal, you will drop their systemic vascular resistance, their SVR. A normal heart would compensate by speeding up and pumping harder. A heart with severe AS cannot. Their blood pressure will bottom out, their coronary arteries won't get enough blood flow, and you can have a cardiac arrest right there on the table. Severe AS is a major relative contraindication to spinal anesthesia.
Okay, that leads us perfectly into Part D anesthetic techniques. This is the core exam question. Discuss the choice of anesthesia for this patient.
Your opening statement should be confident and clear. Neuraxial anesthesia, either a spinal or an epidural, is the gold standard for total hip replacement unless it's specifically contraindicated.
Why? We need to give the examiner the evidence-based reasons.
Correct. You need to list the advantages, and these are your buzzwords. 1. It significantly reduces the incidence of deep vein thrombosis and pulmonary embolism. 2. It has been shown to reduce intraoperative blood loss. 3. It avoids airway instrumentation, which is a huge benefit for a patient with COPD or a potentially difficult airway. And 4. It is associated with better postoperative analgesia and a lower incidence of early postoperative confusion or delirium compared to general anesthesia.
The DVT reduction is fascinating. How does the spinal actually do that? It seems like a stretch.
It's pure physiology. The spinal block causes a sympathectomy. It blocks the sympathetic nerves to the lower body. This leads to vasodilation in the legs. That dilation increases venous blood flow velocity. It keeps the blood from becoming static in the veins of the calf and thigh. It's like turning a slow-moving river into a faster one. It's harder for debris, or in this case, clots, to form. There may also be some beneficial systemic anti-inflammatory effects.
Okay, that makes sense. So when would we use general anesthesia?
There are clear indications. If the patient refuses a regional block, that's their right. If they have a severe coagulopathy or are on anticoagulants, that can't be stopped. As we just discussed, severe aortic stenosis is a situation where you might prefer the tight control over afterload that a GA provides. Or, if the surgery is a very complex revision that is expected to take 4, 5, or even 6 hours, a spinal just won't last that long.
Let's talk about positioning. The patient is on the table in the lateral decubitus position. This isn't just about surgical access. It creates profound physiological changes for us.
It creates a significant VQ mismatch. It's a classic problem. When you turn an anesthetized patient on their side, gravity pulls blood down to the dependent lung, the down lung. But that same lung is being compressed by the weight of the mediastinum and the abdominal contents. So it's getting plenty of blood, but it's not getting enough air. That's a shunt. It leads to hypoxia.
And the top lung, a non-dependent one.
It's the opposite problem. The non-dependent lung gets great ventilation because it's nice and open, but gravity is pulling the blood away from it. So it's getting plenty of air, but not enough blood. That's dead space. You're fighting this physiological mismatch the entire time. You have one lung creating shunt and the other creating dead space.
And what about nerve injuries? There's a famous trap here related to the axillary roll.
Yes, a classic Viva trap. The axillary roll does not go in the axilla. It's a misnomer. If you put it directly in the armpit, you will compress the brachial plexus and the axillary artery, and you can cause severe permanent nerve damage. The roll should be placed on the chest wall, just caudal to or below the axilla. Its purpose is to lift the chest off the bed, taking the pressure off the downside shoulder and neurovascular bundle.
Okay, fantastic. We are in the OR now, Part E, intraoperative management. We're monitoring the patient. The drapes are up. The surgeon turns to you and says, I am about to cement. What is your drill? What is your immediate action plan?
This is all about crisis anticipation. You don't wait for the problem to happen. You act proactively. I want you to remember a simple 3-step prophylaxis protocol. Step 1. Immediately increase your FiO2 to 100%. You want to pre-oxygenate and denitrogenate them. If an embolus hits, you want every single hemoglobin molecule to be carrying oxygen. Step 2. Optimize their volume status. Ensure the patient is normovolumic, perhaps even slightly fluid-loaded. You want to maximize their preload to support the right ventricle when it comes under stress. Step 3. This involves communication with the surgeon. The surgeon should be performing high-pressure lavage of the femoral canal to wash out as much fat and debris as possible before inserting the cement. They should also vent the femur by drilling a small distal hole to allow the high intramedullary pressure to escape, rather than forcing everything into the circulation.
And if, despite all this, the blood pressure starts to drop?
You treat it immediately and aggressively. The go-to is a pure alpha agonist like phenylephrine to restore SVR and blood pressure. If you suspect right ventricular failure is the primary problem, you may need an inotrope like epinephrine or norepinephrine. The main goal is to maintain coronary perfusion pressure at all costs to prevent a secondary ischemic cardiac event.
Can you quickly help us distinguish BCIS from the other embolic syndrome we hear about? Fat embolism syndrome, or FES?
The timing is the key difference. BCIS is an immediate intraoperative collapse that happens within minutes of cementing. Fat embolism syndrome is usually a subacute process. It typically presents 24 to 72 hours after the initial injury or surgery.
And what are the classic signs of fat embolism syndrome?
You should remember Gert's criteria. The major signs are respiratory insufficiency, so hypoxia and ARDS, cerebral involvement, which can range from confusion to coma, and the classic pathognomonic sign, a petechial rash, usually found on the chest, axilla, and conjunctiva. If you see that rash on post-op day 2 in a THR patient, your #1 diagnosis must be FES.
Great. Part F, postoperative care. Let's talk about pain management. This is an exam favorite.
Multimodal analgesia is the phrase you must use. The goal is to be opioid sparing, especially in the elderly, to reduce the risk of confusion, delirium, and respiratory depression. Paracetamol is your baseline. NSAIDs are great if their renal function allows, but the real game changer is regional analgesia, a peripheral nerve block. For THR, the Fascia Iliaca Compartment block, or FICB, is an excellent choice. It's relatively easy to perform and provides good analgesia by covering the femoral and lateral femoral cutaneous nerves.
Why not just leave an epidural in for pain relief?
It's an option, and it provides fantastic pain relief, but the downside is motoblock. It makes it very difficult for the patient to mobilize. It also causes urinary retention and hypotension. Our primary goal post-op is to get these patients up and walking as soon as possible to prevent DVTs. A dense epidural works against that goal.
Speaking of DVT, let's touch on prophylaxis. What is the specific anesthetic relevance here?
The timing is absolutely critical. Our regional anesthesia techniques and the DVT prophylaxis drugs interact dangerously. You must know and be able to quote the ASRA guidelines, the American Society of Regional Anesthesia guidelines, on neuraxial procedures in anticoagulated patients. For example, you have to wait 10 to 12 hours after a prophylactic dose of low molecular weight heparin before you can safely insert a spinal needle or remove an epidural catheter, and then you must wait another 2 to 4 hours after removing a catheter before you can give the next dose. If you get this timing wrong, you risk a catastrophic epidural hematoma, which can cause permanent paralysis.
Okay, we're in the home stretch, Part G exam integration. A very common question is to compare and contrast THR with TKR, total knee replacement.
An excellent Viva question. You should be able to present it like a table in your mind. 1. Surgical stress. THR is generally a higher stress surgery with more potential for major blood loss than a TKR. 2. The tourniquet. This is a key difference. TKR almost always uses a thigh tourniquet. THR never does. So for TKR, you have to manage tourniquet pain and the metabolic and embolic consequences of tourniquet deflation. 3. Embolic risk. For THR, the big risk is BCIS from cementing. For TKR, the main embolic risk comes on tourniquet deflation when a shower of debris from the knee can be released. 4. Postoperative pain. TKR is generally considered to be significantly more painful post-op than THR.
Finally, let's talk about presenting the answer. You're faced with that 20-mark theory question. How do you structure it for maximum marks?
You must use headings, structures, everything. Start with an introduction. Then preoperative assessment, mentioning the 4 M's. Then discuss intraoperative management with a dedicated subsection on anesthetic technique regional versus GA and another on BCIS. Then a section on postoperative care, and please, draw diagrams. A simple flowchart for the pathophysiology of BCIS. Cement insertion leads to high intramedullary pressure, which leads to embolization, which leads to RV failure and collapse, or draw a simple stick figure in the lateral position, clearly showing the axillary roll in the correct place on the chest wall. It saves you writing 100 words, and it shows the examiner you truly understand the practical concepts.
Amazing. Let's try to summarize this entire session. If you had to boil it down, what are the absolute high-yield takeaways for the exam?
All right, here they are. 1. THR is a geriatric procedure in a high-risk population. Assume frailty and multiple comorbidities. 2. Regional anesthesia is the gold standard technique. You must be able to say why. It reduces DVT, blood loss, and postoperative confusion. 3. BCIS is the killer. It's an embolic phenomenon causing RV failure. Your first warning sign is a sudden drop in end-tidal CO2. 4. Prevention is better than cure. For BCIS, that means 100% of O2, optimizing fluids, and good communication with the surgeon before the cement goes in. And 5. The Viva trap. If you see rheumatoid arthritis, your answer must involve assessment of the airway and cervical spine.
That is a true masterclass. I feel like if you can articulate all of that, you're in a very, very good position. Visualize the exam hall, take a deep breath, and nail that long case.
Exactly. My final piece of advice is this. In the exam, don't just list drugs. Show the examiner you are thinking like a consultant. Show them you are anticipating the crisis before it happens. Good luck.
Thanks for listening to this deep dive on anesthesia for total hip replacement. We'll see you next time.